Today we will have the first speaker as Dr. Pramod Kumar Pai, who is going to give a talk on management approach to Parkinson's disease. Dr. Pramod Kumar Pal, sir, is the professor of neurology, movement disorder specialist in National Institute of Mental Health and Neurosciences, NIMHANS. He is currently holding the post of the President of Movement Disorder Society of India, and he is the past President and Treasurer of Indian Academy of Neurology and Secretary of the MDS AOS. His areas of interest are movement disorder, genetics, human motor physiology. I welcome you, sir, Dr. Pramod Kumar Pal, sir.
Yeah. Good evening. Thank you very much for the kind introduction. I thank Neuroscience Forum and IMA for giving me this opportunity, and also thank Dr. Rajesh and Dr. Vikram. So I'll just share my slide first. Am I visible and the slides?
Yes, sir. Yes, sir. Visible, sir.
Okay. So good evening. So I'll be speaking for the next 30 minutes on the approach to management of Parkinson's disease, not necessarily the advanced management strategies, etc., because it is too short a time. But nonetheless, since there are so many students, and this is basically for practitioners and students, I would like to go through some of the management approaches when you diagnose a patient with Parkinson's disease. So let us recapitulate in the first few slides what is Parkinsonism. It is a syndrome characteristically comprising slowing of movements, that is called bradykinesia, scarcity of spontaneous movement, which is also called hypokinesia, tremor of the limbs, usually at rest, but you can have a postural tremor also, stiffness, which is a rigidity type of stiffness usually starts on one side of the body, and later on, but not in the initial stages, impairment of postural reflexes and difficulty in walking and falls. So there are different classifications of Parkinsonism. I do not want to go into the details. Just to tell you that what I'm going to speak is on idiopathic Parkinson's disease with sporadic and genetic cases, and not the atypical Parkinsonian syndromes like MSA, PSP, TBS, etc. But nonetheless, it is very important to know what are these atypical syndromes so that the management approach for a Parkinson's disease become better. And according to the age of onset, the Parkinson's disease, like idiopathic Parkinson's disease, can be classified as juvenile onset PD, that is less than 20 years of age. Early onset PD, it is called less than 50 years of age of onset of motor symptoms, and late onset Parkinson's disease. Now, what are the motor symptoms of Parkinson's disease? As I already told you, the symptoms usually start on one side of the body. Rest tremor is found in about 70% of the patients, and it is like a pill rolling type of tremor in the hands, and later can involve the lips, chin, and jaw. Bradykinesia in later about 90% of the patients. Rigidity in more than 90% of the patients. And as the disease progresses, you get gait disturbances, freezing, postural instability, etc. One of the important things to differentiate between Parkinson's disease and the other atypical Parkinsonism is that these symptoms like tremor, rigidity, bradykinesia respond very well to levodopa or dopaminergic drugs, at least more than 30%, at least in the initial stages of the disease. So there is no definition. So whenever you diagnose a patient of Parkinson's disease, whether some people ask whether it's early PD or late PD, advanced PD or not, because sometimes the treatment management strategies change. So when you say early PDs, when the duration is less than, say, 1 year, and Hoon and Ear stage is about 1 to 2, both sides may be involved, but not the axial symptoms. And when there is no postural instability, no cognitive decline, etc. So this is an example of a very early PD. Like you can see here, tremor of the left thumb, rest tremor. And when another patient disease, or when he walks, there is a reduced arm swing on both the sides. So these patients in the early PD can have difficulty in writing called micrographia. Letters become smaller and smaller. Then reduced facial expression, low volume of the voice, difficulty in thinking, slowness of thinking, And usually all symptoms are one-sided to start with and then become generalized. And there can be vague non-specific symptoms also. And at this stage, it is very important that we differentiate from normal aging, late onset essential tremor, drug-induced Parkinsonism, multiple system atrophy, PSP, CBS, etc. So as the disease progresses, these are little advanced stages of Parkinson's disease, and we see often two types. One is called tremor dominant, the first picture video you're showing, very severe tremor, or some patients can have a rigidity, bradykinesia, postural instability, dominant, what is known as the akinetic P. Some patients can have a mixed phenotype, and some patients can have dystonia. These are very important to recognize because treatment strategies change sometimes based on these symptoms. Now, last part before I go to the real management of the Parkinson's disease, the Parkinson's disease is usually clinical diagnosis. Okay, there is no particular tests to say it is a 100% Parkinson's disease. And there are some red flags. So when you get these red flags, you should consider alternative diagnosis like atypical Parkinsonism, PSP, MSA. Early impairment of postural reflexes, significant gait abnormality, significant ocular disturbances like up gaze or vertical gaze, downward gaze palsy, autonomic dysfunction like significant postural fall in blood pressure, non-related to drugs, progressive dementia. Cognitive dysfunction can occur in PD, but later stages, not in the initial stages. Cerebellar signs, focal neurological deficit, or unresponsiveness to levodopa. If these picture you get this type of signs or symptoms, then you should consider a alternative diagnosis than Parkinson's disease. Do we need to do any investigations? People ask about that. Yes, we usually do imaging, but not the SPECT or DAT imaging or PET scan. It is not required. Okay, unless you have some differentiation problem within Parkinson plus disorders. Usually we do a genetic test. Usually do a autonomic function test in the initial stages to see if there is any postural fall in blood pressure. If you do a SPECT or PET, you will see asymmetric reduction in the uptake of the tracer. And some nowadays, with the advent of genetic testing, a lot of people ask for genetic testing, but it is not a must. Mainly, we do genetic testing after appropriate counseling. Those who have young onset Parkinson's disease runs in the families, and there could be some different type of surgical treatment for genetic test after a genetic testing. Then only we do genetic testing, but usually the treatment strategies doesn't change. Now, what are once you diagnose the patient of Parkinson's disease, what are the general guidelines for management of early Parkinson's disease? So confirm the diagnosis of idiopathic PD clinically as well with appropriate investigations. Look for postural aberration, autonomic dysfunction, cognitive decline, etc., which I told you. If the patient has PD, then decide if the patient needs treatment at this time or not. Suppose a patient is retired, has a mild symptoms of tremor stiffness on the non-dominant side, the left hand, they may not need treatment. It is not that the treatment is going to cure the patient. And explain to the patient and caregiver the nature of the illness and therapy. So this is in a nutshell how we approach a treatment for Parkinson's disease. There are motor symptoms, non-motor symptoms, motor symptoms management, medical management, rehabilitation, physiotherapy, counseling. Some patients may later go for surgical treatment, but again, the medical treatment has to continue, and then treatment of the non-motor symptoms like sleep problems, depression, anxiety, constipation, etc., which I'll come to later on. And then general lifestyle modification, rest, physical exercise, physiotherapy, support groups, interventions, etc. So what is the pre-treatment counseling for the patient and caregiver? The nature of the illness, as I told you, to be explained to the patient that it is a progressive disorder. There is no magic treatment. All patients are different when the doctor treats, and it has to be a tailor-made approach to treatment of Parkinson's disease. So the treatment, whatever you do, it is not curative and it is symptomatic. Give an example of diabetes, hypertension, that they also need everyday treatment. Parkinson's disease also will need treatment every day. Then the realistic outcome, the patient should not think that as soon as the treatment is started, every symptoms improve. The improvement may not be complete. It may take months because it has to be very slowly. It has to be increased, as I tell you later on. Patients may have good days or bad days. Symptoms may worsen with anxiety and stress, especially the tremor. Medications will have different effect on symptoms. Usually the best improvement of the levodopa is slowness, followed by stiffness, tremor, and then the gait and posture stability. Tremor, even if it improves, if there is slightest anxiety, then the tremor may come back. And the course of the disease and response to treatment will vary between two patients. So these we need to explain to the patient very carefully. And also the side effect profile of each drug. So again, tell them that depending on the course of the illness, the dose has to be changed, new medicines has to be added, or they may need a functional neurosurgery like deep brain stimulation. There are a lot of non-motor symptoms, as I told you, and you should also warn the patient, because the patient may be already having non-motor symptoms before the onset of motor symptoms, like constipation, sleep problems, RBD, like REM behavior disorder of sleep, patient jumping out of the bed, screaming, depression, anxiety, sexual dysfunction, impulse control disorders. So it is very important to identify these disorders before starting treatment, because sometimes a patient has impulse control disorders, say hypersexuality or gambling tendencies. So certain of the young onset PDs can have this problem. And in these patients, you have to avoid dopamine agonists. Okay. And then the role of non-pharmacological treatment like yoga, meditation, etc. should be also emphasized. Then, so decide if the patient requires treatment at this stage, and based on the severity of the symptoms, occupation, lifestyle, type of symptoms. And you involve the caregivers for this decision making. You should have a flexible approach. Insist the patient to keep a diary, especially in the later stages of Parkinson's disease when there will be dyskinesias. And if there are fluctuation of symptoms, this may occur and no need to panic, and ensure that the medicines are slowly started and also not stopped abruptly, and ensure compliance and good follow-up. This is in a nutshell the different medications which are available for treatment of Parkinson's disease, mainly replenishment of dopamine in or dopaminergic activity in the brain. So these are the dopaminergic drugs. The dopamine, because the levodopa is still the gold standard, and then dopamine agonist like ergot derivatives we do not use much anymore. Non-ergot derivatives like roperidone and pramipexole and apomorphine, which is also available in injection and subcutaneous injection and infusion. Then we have enzyme inhibitors. These by itself, like peripheral decarboxylase inhibitor, has to be given, but with levodopa. By itself, this does not treat Parkinson's disease. So either we give levodopa plus carbidopa or levodopa plus benserazide. Now, MAO-B inhibitor are very mild dopaminergic activities there. These are rasagiline, selegiline, and safinamide. And COMT inhibitors like entacapone, opicapone, tolcapone is not used nowadays. These increase the efficacy of the levodopa, but by itself they are not treatment for Parkinson's disease. They reduce the inhibition, they reduce the breakdown of the levodopa. Then NMDA antagonists like Amantadine, anticholinergics usually discourage anticholinergics, and unless the patient has a very severe tremor or dystonia or very early age of onset, we do not usually use triaxipinidil, especially in the elderly. Then other things, as I told you. Now, how to start the treatment? So once you decide, I'll tell you later about which drug to use when. But when you start to give a patient a medicine, either you start with immediate release. I usually like immediate release levodopa with carbidopa, or a control release preparation. And we usually start 50 milligram to 100 milligram, gradually increasing every 3 to 5 days. So total dose approximately it will be about. So if you like levodopa, carbidopa, it will be 100 by 10 or 110 or 125, 100 milligram plus carbidopa 25 milligram. So we start in a very slow dose. So like this, I start. Usually we start half tablet. Every 3 to 7 days, you increase by half tablet so that the body accustoms every 4 hourly, or you can give every 8 hourly initially, to a target dose of 1 tablet 3 to 4 times a day. If a patient has nausea, vomiting, go back to the previous dose, gradually increase the dose so that they do not have nausea, vomiting. If they have, take some food and then give the tablet. Do not give it in an empty stomach, or you can give a Domstal tablet half an hour before each dose of these medications. After some time, the patient will definitely be able to tolerate. Pramipexole, roperidone, again, I start very slowly and to a target dose. So either you can give monotherapy or usually we prefer only monotherapy. So I'll show you here roperidone. I start every week by 0.25 milligram, 1 tablet 3 times, and gradually increase to 1 milligram 3 times, and then gradually increase over weeks to 3 milligram, 1 tablet 3 times if you take it as a monotherapy. And pramipexole, again, we start with 0.125 milligram, 1 like this. We increase gradually to 0.5 milligram 3 times a day. Antiviral drug, Amantadine, it is a monotherapy. Sometimes it's a very mild dopaminergic effect is there, but it can cause lots of side effects like hallucinations, confusion. It is usually given 100 milligram OD and then increase it to BID or TID. It can cause pedal edema, swelling, hyponatremia, etc. Then anticholinergics, I usually do not prefer, but if you want to start in a young patient, you can start 1 milligram, you can gradually increase by 3 to 4 days. Then MAO-B inhibitors, selegiline, it can be given 5 milligram with a breakfast and gradually increase it to total 10 milligram per day. Or racegiline, we can give 0.5 milligram a day in the morning and gradually increase to 1 milligram once a day. COMT inhibitors, as I told you, we usually use entacapone with 200 milligram. You can give about 8 times a day, along with levodopa, carbidopa, because without that, it will not act. Opicapone is a once a day dose. It is now available in India, but it is costly. So what are the general guidelines? So when you see a patient of PD, use 1 drug at a time. Absorption of drugs is better in an empty stomach. Most patients are not able to tolerate dopaminergic drugs on an empty stomach. So you have to tell them to take a light snacks and start treatment. Drugs should be taken after light snack or later on, half an hour before a major meal or 1.5 hours after a major meal. Redistribution of high protein content may be done in advanced PD. During escalation of dose, if the patient experiences side effects, you reduce the dose and go back to the previous dose. And as I told you, the domperidone may be given. So these are some of the side effects. I'm not going to go into the details, but mainly it is dizziness, lightheadedness, nausea, vomiting, and gradually it reduces. Okay. So this is the way how I start treatment. So if a PD, then if there's a functional disability is not there, if you diagnose PD function, no, there's no functional disability, no need to treat. If the functional disability is there, then if it age less than 50 years, initial drug option may be dopamine agonist, MAO-B inhibitor or amantadine. Factor determining will be age, affordability, dopamine agonist is costly, non-motor symptoms, etc. If age is between 50 and 70, initial drug is again dopamine agonist, but if it is age more than 70, initial drug of choice is levodopa carbidopa. If there are side effects like sleep disturbances, autonomic dysfunction, psychosis, impulse control disorders, stop the dopamine agonist and just give only levodopa carbidopa. So factors determining the choice of drugs, as I told you already, presence of non-motor symptoms like sleep disturbances, postural hypertension, cognitive decline, impulse control disorders. So if all these are there, then you should actually give only levodopa carbidopa, not the other drugs like amantadine, dopamine agonist, etc. So after some years, after about 4 to 5 years of starting treatment of in Parkinson's disease, 50% will develop motor fluctuations. So what are these? Wearing off. So earlier, even if the patient was taking 1 tablet 3 times, suppose at 8 o'clock and by 12 also, if the doesn't take a medicine, there's no problem. But after few years, the patient feels that he needs treatment. So that's called wearing off. Then unpredictable off and on, delayed on. Then some patients start developing dyskinesia. As soon as they take the medicine, after the effect starts, they develop this type of abnormal movements. This is called on-state choric dyskinesia or ballistic or myoclonus. Okay. Some people can develop off-state dystonic painful spasm, diphasic, and freezing of gait. So these are the time when you need to again redistribute the different medication strategies have to be done, and also you start thinking of advanced therapies like deep brain stimulation or apomorphine therapy. So strategies to reduce the motor complications: take in an empty stomach if there is wearing off, several doses, small doses at a time, crush the tablet and mix with good deal of liquid. So if a patient is on monotherapy, which I usually advise, so if the patient is on levodopa carbidopa, then at this time you may start a dopamine agonist or an amantadine. If the patient was earlier on a dopamine agonist, now at this time you may like to start, levodopa carbidopa, etc. This is when there is a wearing off or unpredictable. The off state is not going away properly. So these are I told you about that. You can give a CR preparation at this time, MAO-B inhibitors, COMT inhibitors, all these things when there is wearing off or no delayed on or reduced on. But once the patient develops dyskinesias, then you stop the CR preparations, don't give entacapone. You can add amantadine, you can add safinamide, and give small doses of the medications. If the patient was too much on levodopa, carbidopa, reduce the levodopa, carbidopa, and now to add dopamine agonists. So this is a patient with very, very severe, you can see here, dyskinesia. Every time she takes the medicine, either she is in this state or she is in a total off state. So these are the, patients can get daily, very exhausted. So there can be rhabdomyolysis, dyspnea, etc. So if a patient comes in the casualty with this type of problems, then you should exclude infection and sometimes dehydration, etc. So stage that is called advanced Parkinson's disease, going to be an advanced Parkinson's disease. What do we do? So there are certain drugs like apomorphine, which can be a rescue therapy, like you can give subcutaneous apomorphine, and there will be initial improvement for about, say, half an hour or so. But it can cause nausea, vomiting, and it is not a cure. So all the advertisement you see of patient being totally cured by apomorphine is not the correct thing. Apomorphine is only a rescue treatment, and if a patient needs frequent doses of subcutaneous injection, which is costly, then you may need to give apomorphine pump, but that is more messy and costly, and probably deep brain stimulation will be better. And the other problem occurs is what is known as this time the patient develops gait freezing, which can be cured by Q, either in the off-state freezing or sometimes in the on-state freezing. In on-state freezing, we cannot do much. Okay, so you can see here this gentleman. So as soon as you give an eye, some visual feedback, patient improves. So this type of visual sensory cues, visual feedbacks have been taken into consideration for physiotherapy of this patient. They can have a cane, a walker with a laser beam falling in front of that, and the patient can walk in a better way. And then also, if there is any freezing, off-state freezing, you can increase the dose of dopaminergic drugs. If the on-state freezing, then you have to see whether there is anxiety. If there is anxiety, you can give anxiolytic. So this is the summary which I was telling you. So if at this state there are dyskinesias, coliform dyskinesias, peak dose of biphasic, or dystonia, peak dose of off state, or motor fluctuations in the on state. So all these things, if whatever strategies I told does not improve, then you have to consider the neurosurgical treatment, which I'll come to. So what are the guidelines? Okay. So what are the neurosurgical treatment available for treating Parkinson's disease? So ablation, that is, we destroy a part of the nucleus, which we think is overactive, like thalamotomy, peridotomy, subthalamotomy. Okay, but subthalamotomy is usually not done because it can cause Basilism. Thalamotomy is usually done for too much of tremor and who cannot afford DBS. Peridotomy is done when there is a patient has dyskinesias and it can be done only on one side. These are all can be done on one side. So you must be hearing about what is known as magnetic resonance guided focus ultrasound. It is a non-invasive. The skull is not open, but it can be done again in the same. It is otomy, that is a thalamotomy or pyrotomy, and which we are doing already by stereotactic radiofrequency surgery by just giving a heating and ablating the area. And sometimes patients can give by radiofrequency gamma knife also. But the problem with this is that can be done only on one side, and thalamotomy will treat only the tremor, not the rigidity or bradykinetic. Okay, so this is not a obvious choice unless a patient cannot afford DBS, and they can go for a stereotactic radiosurgery thalamotomy for severe tremor, which I'll show you in one patient, and a pyrotomy, but this cost some few thousands and in the government hospital, and it is much cheaper. Suppose you want to do a MR guided high frequency ultrasound lesioning, that same 10,000 which we do in government hospital will cost about 20 lakhs for one side. Okay, so it is not much worth unless a patient can spend money and there is a contraindication for DBS. Now, deep brain stimulation is done either for subthalamic nucleus or for GPI or for ventral intermediate nucleus, that is the VIM. VIM is done mainly for tremor predominant. If there's a dyskinesia predominant and you want to reduce the medications, GPI is done, subthalamic nucleus is done for most of the patients of PD. GPI stimulation has a better cognitive profiling. So who are the good candidates for deep brain stimulation? Only those candidates who adequately respond to dopaminergic therapy are the candidates. Okay, DBS will not improve what is not being improved by the dopaminergic therapy. So gait, freezing, your speech problem, balance problem will not improve if a person after deep brain stimulation. What deep brain stimulation does is that when a patient has severe dyskinesia, cannot tolerate the large amount of medications, we do a deep brain stimulation where the off state, severity of the off state reduces, the on state become more, and the on state with dyskinesia reduces, on state without dyskinesia increases. Why? What happens is that when you do either GPI or subthermic nuclear stimulation, the medications we can reduce by about 50%, sometimes about 70 to 80%. And then the medication-related side effects like dyskinesia come down. So in general, for the first few years, the patient has a good improvement in the quality of life. And this also, only one thing is that what I told you that unless the levodopa improves the symptoms, we cannot do DBS. There is only one exception is that medication-resistant tremor. So if there is the tremor doesn't improve with levodopa, still we can do a deep brain stimulation. But though who are the poor candidates who have severe dementia, severe autonomic dysfunction, poor dopaminergic response, atypical Parkinsonism, unstable psychiatric illness, absence of a dedicated caregiver, because caregiver is important to bring the patient for programming. And also the cost is quite prohibitive. Still, in the government hospitals, it will cost about 17 lakhs for doing a DBS, that is a rechargeable battery. So it should not be done. So I'll take another 5 minutes. So should be responsive for levodopa, except tremor. And usually age range is less than 70 to 72 years. What may improve after DBS? Any symptom which does improve with levodopa except tremor, speech, balance, freezing, and so these may not improve after DBS. Speech, balance, freezing, and cognition. What may worsen? Gait, speech, mood and behavior, and impulse control disorder. So here you can see here a pre-lesioning, very severe tremor, and you can see here after the lesioning, after a thalamotomy, the tremor has significantly improved. This we have done only on one side, that is the left side thalamotomy we have done. Okay, so this is a tremor dominant PD who did not improve with levodopa, and you can see here before the DBS, and soon you will see after the DBS. And this is a rigidity dominant bradykinesia dominant PD, akinetic rigid. Before the DBS, very slow, and you see the other patient is fully recovered, the tremor. And this gentleman, I showed you the video earlier, and this you can see here has difficulty in walking, and you soon see after the DBS on state there is a significant. So post DBS is off state, so a significant improvement in the facial expression and bradykinesia. Okay. Now, management of just few slides on management of non-motor symptoms in early PD, constipation, depression, fatigue, sleep disturbances, etc. So you can see here the timeline for Parkinson's. We see the patients at this stage when the motor symptom starts. But before that, even 20 to 50 years earlier to that, you can have REM behavior disorder, sleep, depression, constipation, anxiety, hyposmia, etc. So these non-motor symptoms are very important. So if the patient has constipation, you should stop anticholinergic drugs, use stool softener, laxatives, and later on maybe enemas. Patient has swallowing problems, you have to increase the on time, and sometimes we can give injection of botulinum toxin in the parotid glands. If there is symptomatic orthostatic hypotension, if a patient is orthostatic hypotension, you think of MSA. But it is not in MSA, patient is responding to levodopa, then you can try behavior modification, increase the salt and fluid intake, elevate the head end of the bed, and then later on stop the Amantadine or trihexyphenidyl or dopamine agonist. And if still there's a problem, or you can give elastic stockings. If still there's a problem, then you can give fludrocortisone or midodrine. Insomnia is like any other treatment. We have to give judicially, we have to give the hypnotics. But if there is too much of REM behavior disorder of sleep, you have to give either clonazepam, you can give, which will be significant improvement, or melatonin we can give. And excessive daytime sleepiness, some of the drugs like Primipex, etc., can cause excessive daytime sleepiness apart from patients with Parkinson itself. So you have to reduce the anti-PD medications and sedating drugs. If there is too much of TLMS and all, you can use diazepams or clonazepam. There are urinary dysfunction and sexual dysfunction that are treated to be assessed by their own merit. I will not be going into details because of shortage of time. These are the main things, if there's a urinary symptoms, then medications to treat urinary urgency, chronic urinary retention and difficulty in voiding, different type of treatment, but you should always rule out a prostatic hypertrophy, and then functional incontinence, then bedside commodes, adult diapers, etc. For sexual dysfunction, again, proper clinical examination, because we see a lot of young onset Parkinson's disease, and there you need to treat sexual dysfunction, and sometimes the treatment are given like treatment for depression, etc. Approach to the, so I'm just not going to go into the details, but sometimes the patients can have ICD with a hypersexuality, and in that case you have to reduce or stop the dopamine agonist, and sildenafil can be given for erectile dysfunction. Depression is very important. In the lifetime, you can have about 90% of the patients having depression. More than 50% usually have depression, and usually we prefer the SSRIs. There's not much time to go into that, but in very severe depression, you can have ECT may be needed. Anxiety is also very important. About 40% of the patients, and clonazepam or drugs can be helpful for anxiety. I'll just skip this. So another important thing is the pain and fatigue, which we should always treat and ask for. The most important thing are some of the patients develop psychosis. Here, visual hallucinations mainly. And in these cases, if you identify the early hallucinations like sense of presence or somebody is going in front of you, so then you should stop all the drugs except levodopa, carbidopa, like Amantadine, MAO-B inhibitors, trihexyphenidyl, etc. And then if it is doesn't improve, so these are the things how you can go into this. So gradually stop, for all these drugs, just keep on levodopa, carbidopa. If there's an acute onset of psychosis, rule out infections, drugs, metabolic derangement, etc. If still not controlled, then add quetiapine, clozapine, or olanzapine. And now recently we have pimavanserin, just has been marketed in India. It is about 34 milligram once a day, but you should look for prolonged QT interval and contraindications. Okay. Yeah, I already told you about the ICD, where if there's ICD is there, stop the dopamine agonist. And so I just cognitive decline, if it happens in PD, then there is not much of a treatment. You have to judicially use donepezil or rivastigmine and cognitive retraining. Emergencies in Parkinson's can be plenty. It could be unrelated to the falls or related to the falls, aspiration, and acute psychosis, etc. And if there's the NMS, Neuroleptic Malignant syndrome, then you have to admit the patient, look for any reversible causes, renal failure, aspiration, pulmonary embolism, and dantrolene and bromocriptine are the drugs of choice. So to conclude, management of Parkinson's disease is often challenging and is best managed by a multidisciplinary team. Apart from the motor problems, non-motor symptoms are equally disabling in many patients. These should be detected early and treated. The treatment often needs to be individualized for a particular patient. Deep brain stimulation is beneficial in selected patients and often significantly improves the quality of life of both patients and the caregivers. And finally, non-pharmacological therapies like exercise, gait therapies, speech therapy, yoga play a significant role in the overall management of patients of Parkinson's disease. I thank you for your attention. Thank you.
Now we will have the second speaker, Dr. A. Rajesh, the consultant neurosurgeon, founder of the Dr. Rajesh Neuro Center. Medical schooling from Tirunelveli Medical College. He has a gold medalist in surgery during his undergraduation. He continued his passion in surgery during his doing his super specialty neurosurgery, India's Prime Institute of Neurosurgery, Madras Medical College. He did his endoscopic fellowship training in Jabalpur Medical College. He was a former consultant of the Apollo Hospitals. He was a consultant neurosurgeon and a assistant professor at the Institute of Neurosurgery, MMC, Rajiv Gandhi Institute, Chennai. He is an experienced neurosurgeon performing neurovascular surgery, neuroendoscopic surgery, neurotrauma, spine surgery, bulbous, and neuro-oncology surgeries. Founder of the Dr. Rajesh Neuro Foundation, Nagarkoil. Welcome you, Dr. Rajesh, for your lecture.
Thank you for the opportunity given. So today we are going to see the topic on Basilar of Aneurysm, and this is a debut speech of mine in a public forum. And please bear with me in case of any faults. So usually when we were studying the Basilar of Aneurysm, what I thought was it is not our job. It's a job of intervention radiologist or intervention that is neuroendovascular surgeon. So I was not interested in that initially. So when I started operating on other aneurysms, and I was able to look into the area where the basilar top was, that is the basilar artery was there. So then I decided to take upon the basilar top aneurysms in the due course. Right? So now before going into the actual basilar top aneurysm, we will see about small anatomy of the basilar artery. So as we all know, the basilar artery comes with the union of vertebral arteries and its system that rise in front of the brainstem. And the basilar artery actually doesn't bifurcate; it actually quadrificates into two posterior cerebral and two superior cerebellar arteries, and it is actually communicating with the ICA by the posterior communicating arteries, and it also has many perforators that supplies the brainstem directly. And the surgical, that is in before going to that is in the surgical point of view, we have to take into consideration some variations in the anatomy that is very important for the neurosurgeons. So number one is the fetal PCA. In case of fetal PCA, the PCA will be of a larger caliber. In those cases, in those cases we can see a hypoplastic P1 in the operating area. And in case of an hypoplastic posterior communicating artery, the PCA will be of a larger caliber. And in other the other variations that are noted are the arrangements of the perforators from the that is the PCA and the basilar artery. That is, the perforator can come from both sides. It can be symmetrical from both sides bilaterally. It can be asymmetrical. That is, the perforators can be of much number on one side than the other. And the third one is the perforator can arise from a single branch from one side and supply the other things. And this is called as artery of Percheron. Okay. So this is for the anatomical consideration before moving into the surgery. And taking into account the basilar aneurysm surgeries, we have to look into the posterior clinical process. So this is the bony process that actually comes in the way while we do basilar artery aneurysms. So in this you can see there are two arrangements of the basilar arteries. One is low lying and another is a high lying. Low lying basilar artery aneurysms means the top of the aneurysm will be below the top of the posterior clinical process, whereas the high lying will be completely above the superior clinical process, which will be easily surgically amenable. Whereas if we want to address the low-lying aneurysms, we have to remove the part of the posterior clinical process before reaching into the aneurysms. And now the surgical corridor. What are the surgical corridors that we have during encounter? That is during the encounter of the basilar arteries. Actually, in this picture you can see the optic nerve, the internal carotid artery that is coming, and the internal carotid artery actually bifurcates into the ACA and the MCA. So taking into consideration the triangle number one, the triangle number one is the optico-carotid triangle, which is formed by the optic nerve on one side, the internal carotid artery on the other side, and the ACA, there is A1 on the other side. So this is called as optico-carotid triangle. And when we go through this triangle, we encounter pituitary stalks and the mammillary body. Whereas the second triangle is carotico-oculomotor triangle. So actually in this you can see the ICA and the M1 on one side, whereas the oculomotor nerve and the temporal lobe on the other side, the tentorium on the other side. So this is actually a best triangle to access the basilar apex aneurysms because of the there is little availability of important structures on the way when we encounter this aneurysm. The third one is the supracarotid triangle. In the supracarotid triangle, actually this is formed by A1 on one side, that is the ACA A1 on one side, and the M1 on other side, and the frontal lobe on the medial side. So we have many perforators running from the A1 and the M1 to the frontal lobes, which we encounter before accessing the basilar apex aneurysms. And we also encounter the basal ganglia endothelial capsule. That is, these perforator actually supplies the basal ganglia endothelial capsule and the thalamus. So when we damage these perforators, we can have the deficits of this. That is the hemiplegia, then movement disorders. That is these are the symptoms that we can have when we damage these perforators. So this is the surgical corridor, and the best corridor to operate is the second corridor, which is the carotid oculomotor triangle. And textbooks says, and that is textbook says the best craniotomy for this is the diurnal craniotomy, that is FTOC, in which we have to remove the part of frontal and the temporal bone along with the zygoma and the part of orbit. Yeah. So before going into the basilar apex, actually what we have to do is we have to split the sylvian fissure before entering into the triangles. So before entering into the sylvian fissure, actually, if we decompress the brain by doing an EVD or a shunt, the brain will be little bit lax. So this actually happened in one case. When I was doing my first case, the patient was having a hydrocephalus. So what I did was I did an shunt on the other side, then opened the craniotomy on this side, and I was very happy to see that the frontal lobe and the temporal lobe was very much shrunken. That is, it was very much shrunken that it was very easy for me to dissect through the sylvian fissure and go to the basilar apex. So then I decided, instead of doing a large craniotomy, why can't we compress this brain before entering into the basilar apex? So what I did in the second case was, that is, I did an EVD on the same side because there was no hydrocephalus. So did an EVD on the same side, decompress the brain, and then and again I was happy to see the frontal lobe and the temporal lobe, which was very much shrunken, and the sylvian fissure can be easily split, and I can actually go into the basilar apex very easily. So this is how when this is how we see when you open the sylvian fissure. So when we reach the basilar apex, this is how it looks. So this is that is ICA on one side. Then the posterior cleaner process may be visible if it is if it is actually larger, and the MC on the other side, the oculomotor nerve on the on one side, okay, with the temporal lobe on the other side. This is the view when we see in the deeper dissection. Yeah. And we have to take into account the projection of the aneurysm before entering in that. So the number one, what are the projections that we have? Number one is a superior projection, in which it is a direct superior projection of the aneurysm over the basilar bifurcation. And the second one was an anterior projection. Okay, in this, actually we have to go beneath the aneurysm to clip it. And third one is the posterior dome projection, in which the perforators will be lying over the aneurysm. So we have to be very careful while clipping this aneurysm by avoiding it. Actually, see this in this picture. You can see the posteriorly pointing aneurysm is actually clipped by avoiding the perforators. And then, as I already told, the high riding and the low riding. When the basilar apex aneurysm is high riding, it can sometimes that is go behind the ICA itself, and it can create a blind spot behind the ICA. It will be that is, we will have some difficulty in accessing that. And in the low lying thing, what will we be in between our view is the posterior glenoid process. This posterior glenoid process has to be removed. There is a mark that this has to be removed before accessing the aneurysm. And these are the clipping techniques. The superior is actually very easy to clip. That is, we can directly clip with the titanium clips. Whereas the anterior needs some assistance to visualize the neck of the aneurysm by moving the fundus. And the third one, the posteriorly projecting dome, is little bit difficult because we have to avoid the perforators before clipping the aneurysm. So after seeing the that is shrunken brain, what I decided then not to go for a bigger craniotomy. So what I did was I removed the zygoma. I modified my technique in the second case. Then what I did was I removed the zygoma. That is, I did a craniotomy. I removed the zygoma, retracted the temporalis muscle till the base. Then I drained the CSF either by a shunt or by an EVD. Then did a Sylvian dissection, entered through the above triangles and entered the basilar apex. Then I took care of the perforators before clipping it, and then dissected all around and saw the vessels all around. Then clipped the aneurysm. And even after clipping, we have to look for the vessels if it has been entangled inside the clips. That is the other branches if it has been entangled inside the clip. So these are the last two cases that I clipped. One was directly superiorly pointing aneurysm. Both were actually superior pointing. One was a very small aneurysm, and the second one was a larger aneurysm. Now moving on to the surgical video. Is my video visible? Hello?
Yes, sir. Yes, sir. Yes, sir.
Yes.
So play பண்ணுங்க sir.
Play.
Yes, sir. Going on.
Yeah, actually, this is the second case. There is a larger aneurysm. You can see the basilar artery that is coming from the right side. So this is the right side. You can see the basilar artery, and the aneurysm is actually on the left side. That is, the pointer is actually is over the aneurysm, and you can see the branches of the superior cerebellar artery and the posterior cerebral artery in the what to say in the in the upper part. Okay, so that is the aneurysm, and here you can see the opposite side, posterior cerebral and the superior cerebral, you can see on the inferior side. So this is the clipping. The surgical field is actually very narrow because I don't use retractors. I usually use my suction as a retractor. So the aneurysm is being clipped now. This is the second one. This is actually a smaller aneurysm. It was a smaller aneurysm. You can see the aneurysm here. Actually, there was very much fibrosis around the aneurysm, and you can see the posterior cerebral artery on either side. can see the posterior cerebral artery on the other side. Still a small, actually it's a small aneurysm, easily clippable. Yeah. So, and post-operatively, actually, I had a small, what to say, there was a little bit deficit for my patient for 1 week. Then the patient recovered in the case of larger aneurysm. Whereas a smaller aneurysm, actually, the patient was asymptomatic post-operatively. And the take-home message for the basilar artery aneurysm is that is the basilar top aneurysm is actually surgically amenable, and preoperative evaluation of the anatomy of the aneurysm and its relation to the surrounding structures, that is study of the relations to the surrounding structures in the preoperative imaging in the CT angiogram and in the DSA is very, very important. And preparation of the surgical armamentarium is very, very essential in case of clipping any aneurysms. And a good brain decompression by letting out the CSF gives more space to move around the aneurysm, so decreasing the requirement of a larger craniotomy. So this is what I actually had an experience in my cases. Yeah. Thank you. Thank you for the opportunity. So actually I decided that even basilar top aneurysm is also surgically easily amenable, and now I can do such, that is we can do such, that is clipping of the basilar artery aneurysms after examining the aneurysm, instead of sending the patient for coiling or other things. And actually coiling and other Y stent, then other flow diverters actually is out of the scope of this topic, so I did not touch on that. And thank you for the chance. Do you have any questions?
Dr. Rajesh, it is a nice talk.
Yes.
Now the floor is open for discussion. Those who have questions can please.
That was a good surgery exposure, Dr. Rajesh. It is wonderful indeed that you used that particular window, the carotid oculomotor window. Was there any third nerve palsy or anything like that for the patient?
No, sir. No, there was not that. There was no third nerve palsy for the patient. Actually,
Well,
patient had a mild hemiparesis after the surgery, but which improved within a week.
Excellent. And you know, the International Subarachnoid Hemorrhage Trial, as well as the American Stroke Association 2023, you know, highlights that for all basilar aneurysms, the first method of treatment should be endovascular coiling rather than surgery.
Yes.
What is your view on that?
Yeah, initially I was also actually thinking like that, but when I did this aneurysm, I thought that this basilar top aneurysm can be surgically amenable with a good brain decompression, because when the brain is decompressed better, we have a big space to see the, because we are not actually moving into this that area because of the what to say, the complex anatomy around. Whereas when the brain is decompressed much, so we have a good space to visualize this basilar top, so which can be clipped, except in cases of some very low lying basilar top aneurysms or like that.
Can I ask you, Dr. Rajesh, for a basilar aneurysm today, which is preferred actually? Is it surgery or is it coiling?
Yeah, that depends upon the pre-operative evaluation of the angiogram. So the textbook says that endovascular is a best modality of the treatment, but I think after careful evaluation, and if there is a surgical and if it is surgically amenable, we can try clipping the aneurysm. And you know that clipping is a gold standard for any aneurysm. So if it is possible, we can give a chance.
Sir, actually, it is depends on the surgeon's expertise.
Yes, yes.
Exactly.
That is number one.
Exactly.
Number one. Number two, the perforator is the major issues in basilar top.
Yes.
Clipping is not a big problem at all. Preserving the perforator. It all finally depends on the chiasm length, the carotid length, the interoptic space, the carotid third nerve space, if all are favorable and if the aneurysm size is smaller, clipping is always preferable. We have been clipping basilar top for years together. But when all these become little more easier with coiling, the paradigm shift happens towards coiling because people found that is relatively little more safer even in lesser hands than the experienced hands for clipping. That's why international trials have moved for basilar top towards coiling than clipping. But the main advantage of clipping is you are occluding the neck completely. Once you occlude the neck completely, the chance of progression of the aneurysm is very, very, very less. But if you are only coiling, there is always a chance the aneurysm can still progress and rupture. That is one. The another two is the flow diverter. The flow diverter changed the system totally because it totally takes off the aneurysm flow towards the rest of the vessels. So the flow diverter totally changed the basilar top aneurysm treatment modality. And even now, we many a time face with all aneurysms after coiling, the aneurysm still ruptures. It comes back to us for clipping and shifting of standardized caries like only cavernous segment and basilar are ideal for coiling, and all the other aneurysms are ideal.
End of the session. So next month, which day we will be having our program?